Lindsay, thank you so much for. I apologize for interrupting you on the last video. I've been corrected, so I'm not going to do it this time.
Not at all.
Now, I know you've been having some really interesting discussions with your Brazilian colleagues on mouthwashes.
Yes.
I'm intrigued. Tell us whatever you like.
Yes. So this is very curious because previous to this, I had not thought of mouthwashes as possibly being effective against SARS-CoV-2. So I came across this study from the University of São Paulo, and their clinical studies have yet to be, they're actually in peer review right now. But they have come across a very interesting discovery. So they had this dye, and it's called Phthalocyanin Blue. Okay, and so this is a dye that is not active. Okay, and they took this dye to their laboratories, and they were able to manipulate it in a way that I'll show you the phthalocyanine. Here you go. That's the molecule.
Cool. And that's a particular color, is it?
Yes, phthalocyanin blue.
Okay.
So this comes from a family of different dyes that are bioactive, okay? But usually they are activated from being exposed to light, okay? So the people in the University of São Paulo, they took this dye to their lab, and I don't know what they did to it because this is now under patent. And they were able to manipulate it in a way that it did become antiviral, and they are seeing that now in clinical trials. Now, prior to the COVID-19 pandemic, they observed that this product was already antimicrobial. They were going to market it as being used for bad breath, okay? And there was one other thing they were using it for tissue regeneration, okay? And so they had this product, and it was ready to go, and it was already approved by, say, the equivalent of the FDA in Brazil, which is called Anvisa. So it was approved, it was ready to go, and then the COVID-19 pandemic hit, and they started studying this mouthwash against SARS-CoV-2. So in vitro, it was shown to be 96% effective in inactivating the virus. Okay. Yeah. And then what they did is they went to clinical trials. Are you with me, John?
Yeah, I am. Yeah, I am.
Okay. So they went into clinical trials. They started with just a few people, and then their main trial that's now being peer reviewed, they had 41 people that were PCR positive in hospital. So half of those, and this was a triple blind study, okay? Half of the people received a placebo, and half the people received a mouthwash. Now, it's interesting that they observed that about 40% of positive cases of people present with mouth ulcers. I did not know that part. That
really?
Yeah, and so they think that mouth ulcers could be a symptom of COVID-19 infection. So, and they also know that the virus does take up residence in, we know the respiratory tract, but sure, also in the salivary glands and in the throat, and that's why you see mouth ulcers. I didn't know that. Okay. So half of the people in hospital received a placebo, and half of the people received the mouthwash, and they had to use it as a rinse, but also a gargle. Okay. And the results that they have had were that there was a great reduction in the length of hospital stay in the people that used the mouthwash. And then the people that were in the placebo group, actually, I think a third of them went on to ICU, and half of them did pass away. So this was a quite remarkable evidence. And now they are expanding into different trials in different areas of Brazil. They are using this in hospitals for healthcare workers because they're trying to see if it's preventative. And they're also using it in a small community in Brazil called Uru. It's a community of, I think, about 1,500 people. They're trying to see if they know that this mouthwash can reduce the severity of disease by reducing viral load, but they do not know if it can reduce transmission and be preventative. But the study link is up on, we'll put it up on this page. Very, very interesting. And the product is called Phtalox, the product that they've engineered. So it was a very, very interesting interview. And one other thing that I didn't realize was that countries like Japan, they actually have been telling their populations, whenever there's a respiratory virus or anything like that in a population, they say social distance, wear a mask, wash your hands, and use mouthwash.
So I didn't know that. This is so interesting.
And
then that's part of Japanese culture, is it?
It is, and even in Vietnam, that is something that they've been doing, and we know that Vietnam has been very successful in containing this virus. I think in Japan, from what I remember, I think they've seen a 78% increase in use of mouthwash and mouthwash sales since this thing started. So it's a simple solution. And I know that there are other studies with other mouthwashes, but from what I've seen, they are in vitro. And this is an in vivo randomized controlled trial that is showing incredible efficacy. So definitely something to keep our eye on.
And so simple.
Yes.
When I first heard this, I thought the virus is in the nasal passages. It's in the oropharynx, where you can't do a mouthwash, you'd choke to death. So I thought if it's restricted to the mouth, even when you're gargling, it's still only going around the tonsils and the adenoids. It's not going into the oropharynx. Otherwise, you'd be gagging. So I thought it's not getting to where the virus is. But now it seems there's so much virus in the mouth. And also, the other thing that occurred to me is when you're gargling and mouthwashing, you're breathing in the fumes, which are going into the nasopharynx, the oropharynx, and the trachea and the bronchial passages, and right down to the alveoli. So there's probably some molecules going down from that, if it's in a more gaseous form.
And that's what Dr. Villena, who I interviewed, I did ask him about that. And he said that it is important that you use this not only as a rinse, but as a gargle, because when you gargle, you will produce aerosols that can get into the nasopharynx area. So they are testing this as a nasal spray. They're testing it as an oral spray because they're trying to see, do you really need to, how much of it do you need for it to be effective? And so, I also found that to be quite intriguing because it's something that I hadn't understood until I asked the question.
I did not know gargling caused aerosolization. That is right, fascinating. Now, you've said this is effective in vitro. Now, that just means in laboratory conditions, doesn't it? Literally in glass, where you can use high concentrations.
That's right.
And we've seen this with other medicines where they're effective in vitro, in the lab, but that doesn't transpond into the human body, into the in vivo, in life situation. But this does seem to be working because it's reducing the overall viral load. So suppose only 10% of the viruses that are infecting the body are in the mouth. If you can reduce that, then you're reducing the viral load by 10%, just to make up a silly number. It could be 20%. Who knows? So this is actually sort of coming together and making sense now. It's and
it may prohibit the virus from disseminating throughout the body, right? So if it's housed in the salivary glands, it's housed in the respiratory tract, and we can attack that before it disseminates, it might be quite crucial to treatment, actually.
Absolutely. And all the time when we're lowering the viral load, there's some viral antigenic material still there. So you're still getting the stimulation of the immune system.
Yes.
So the 4, 5, 6, 7 days it takes for a good immune response to kick in is achieved when we've got a lower viral load. So it's kind of the same rationale, really, as protecting myself from an infected person wearing a mask. I get a lower viral load. It tends to be in the upper respiratory tract. That gives my immune system more time to make resistance.
That's right.
Before the virus is getting down to my lower tract. So therefore, it makes perfect sense that could reduce severity of disease, because it's when the virus gets into the lungs and the lung tissue and the alveoli that's going to cause more severe disease. So it all makes a lot of sense. There's an old-fashioned principle you'll probably remember, Lindsay, called variolation.
Yes.
For smallpox, where they gave people very small doses of smallpox to generate immunity. Not always a good idea. Some people died from it. But the principle is the lower the viral load you can get, the more opportunity the immune system has to start doing its thing and start getting cracking, producing immunity before it's diffused into more sensitive tissues of the body. I like it a lot. So they knew this mouthwash was antibacterial.
Yes.
And and the halitosis, bad breath, is largely caused by bacterial deposition in the mouth. So that's why we use mouthwashes, and it's good. Also, we know that mouth bacteria are related to a host of other diseases now, don't we?
Yes.
Inflammatory diseases, a whole range of inflammatory diseases, even atheroma, in the arteries. Can be related to dental hygiene, so that's interesting. But my question is, this preparation that your colleagues are using in Brazil, I can't go out and buy it yet, but
No.
I would like to get the protection that you're discussing. So,
I would too.
So is there antiviral mouthwashes that we can? I mean, are most mouthwashes that we use antibacterial, or are they antiviral as well?
So I know that there have been some studies, particularly the one that I can recall right now is with Listerine, Cool Mint, I believe, and it is showing some efficacy in vitro. And I did ask Dr. Vilena about other mouthwashes, and I know that in Japan they have been using an iodine formulation that seems to be somewhat effective, but it doesn't sound like it would be very palatable. And so this product sounds like it's much more palatable. I actually have a family member in Brazil who actually got some of this and has been using it, and they said it's actually even easier to use than regular mouthwash. It doesn't give you that stinging sensation. It's quite pleasant. However, no, we cannot get it right now outside of Brazil. There's huge demand for it, and then there are regulatory issues in getting it out of the country. Yeah. So that is a challenge right now. But for right now, I don't see any problem with people using some kind of a mouthwash as an addition to mask wearing and all of the other public health precautions that we are taking right now. I think that there may be something to it.
I do. I mean, a regular mouthwash that you buy from the supermarket shelf or from a pharmacist, that's routine. It's not going to do you any harm. I don't think we're not promoting iodine on this, because a lot of people, well, not a lot of people, but a minority of people can be allergic to iodine. So we would always advise people to consult their doctor or pharmacist personally first, of course. Always. But having said that, I've been in areas of the world where the water supply wasn't drinkable.
Yes.
And what I would do is I would get a couple of liters of what was basically dirty water. Yeah. Put in just a couple of drops of iodine, leave it overnight and drink it. And it did taste good, but it was drinkable. But as a mouthwash, it would have been fine with very low volumes of iodine in, because iodine kills everything.
Yes, iodine we use it as a surgical antiseptic, right?
Every bacteria, every virus, iodine. There's two things that kill everything. There's iodine and silver.
Yes, silver.
They'll kill absolutely everything. So, well, what about low-dose hydrogen peroxide, Lindsay? Is that antiviral? Do you know?
Yeah, I did ask him about that. And my understanding with hydrogen peroxide in general is that we don't use it anymore on healthy tissue, because it can possibly damage healthy tissue. And I don't really know in the mouth. I know that some people have been using it, but as far as efficacy and antiviral effect, I am not sure about that right now.
I mean, it would be a very dilute solution if you were using it at all, but okay, so perhaps not the way to go. So I'm certainly going to carry on using my regular mouthwashes that I buy from a supermarket shelf that my dentist recommended, and that is. I love things that are simple.
Yes, I know.
Accessible to the whole wide world. And it's just beautiful in simplicity. So we'll look forward to more efficacy data on that. But it's also a risk-benefit analysis. If something's not going to do any harm. That's
right.
People often ask me about homeopathic pills. I say, yeah, take all you want. Won't do any harm. It won't do any good, but it certainly won't do any harm. So
yeah, we don't have evidence. We don't have evidence for it. So
no, we don't. But it's always that risk-benefit analysis, which is the thing that people should just discuss with their own pharmacists and their own doctors and act accordingly. Now, the news reports, particularly in the States, don't know what it's like in Canada, not so much in the UK, seem to be very concerned that two people who had a very strong history of allergic disease in the UK, but nevertheless these two people wanted vaccinated, because they are in a high-risk occupation, they're hospital workers, that they had these anaphylactoid allergic reactions. There seems to be a lot of concern about that. Do you share this concern, Lindsay?
At this point, I do not. I would say that these reactions are to be expected, especially when we are vaccinating large quantities of people. We will see anaphylaxis. We will see other side effects. Some people will have side effects to different degrees. Someone might say, I just had a mild headache for an hour or two. Another person might say, you know, I was out with a headache for a couple of days. I mean, some of these responses, not anaphylaxis, but some of these responses are a good sign that the immune system is recognizing what's going on and it is going to produce antibodies. So I am not too concerned at this point with 2 cases of an anaphylactoid type reaction.
And then they're both okay. In hospital, when we give medicines, this is so innate. We call it birthdays and allergies. So every time, you know, I did 3 years in A&E recently, and every time before you give a drug, what's your name?
Yes.
Two people could have the same name.
Yes.
So what's your date of birth? Now, I suppose it's possible you could get 2 people in the department who've got the same name and the same date of birth, but it makes it less likely. So what's your name? What's your date of birth? Any allergies? Now, you might have just admitted that person 10 minutes before, and they've said they've no allergies. But every single time before I give a drug, a vaccine, anything, what's your name? What's your date of birth? Any allergies? Every single time, birthdays and allergies. Now, this is something that is absolutely fundamental to healthcare. We've known about this for decades. And for 2 people who are predisposed to this, to get these reactions, doesn't surprise me or concern me at all. So I'm pleased you agree with that.
Yeah, and here as well, people are always screened. We have even a consent form where you have to check off a box or list your allergies. So this is something we screen for. And there's a reason that when people are in a healthcare setting after a vaccine, they are asked to wait 15 to 20 minutes. And that's in the rare case that you have an allergic reaction. With most vaccines, it's about 1 in 1 million people. So that's something
that really puts it into context. 1 in 1 million. That's a good number, isn't it?
So when we're vaccinating millions, we are going to see this, and I think people need to know not to be alarmed when this does happen. Just like we will see people have heart attacks, you know, a couple of weeks after their vaccine, or strokes, that kind of thing, right? So these are terrible occurrences, but these things are still going to happen. Whether you had the vaccine or not. It's important for people to be aware of that.
I was actually looking at the paper for the Oxford AstraZeneca vaccine, and there was actually 4 deaths occurred in the study. 1 person was a road traffic accident. 1 person died of blunt head trauma, presumably from a fall. 1 person was actually murdered. I think it was in Brazil.
I think that was Brazil, yeah.
Yeah. And another person died of some unrelated causes. So, you know, clearly, if someone is going to shoot you, that's not caused by a vaccine. So, you know, as you say, when we're dealing with these large numbers, we get these percentages. So we would expect that. What people don't know is perhaps one of the most common drugs to cause allergies is aspirin or non-steroidal anti-inflammatory drugs. I mean, but these are things people take routinely, and but the risk is there. It's anything that's going to work has got a risk.
That's right.
But having said that, if we could if we could make this vaccine safer for people that do have a history of allergy, then that would mean that we could tell people who have a history of allergy not to worry. So yes. I have no history of allergy, so I would have no concern to take this vaccine. If someone came in and gave me it now, I would take it. I have no concern at all. But if someone has a history of allergy, we don't want to exclude those people from vaccination.
Well, and that's why it's important to have a diverse portfolio of vaccines, which is what we are going to have. We will see that some vaccines for certain populations won't be as effective or recommended in those populations, right? So that's why it is important. It's good that we have a few candidates coming. Yeah.
Have you any hunches of what it might be in the Pfizer vaccine that did cause this, albeit very rare?
I do have a hunch. So this is not confirmed. This is just speculation at the moment. However,
just you and me talking, Lindsay. No one's listening.
That's right. Yeah. However, I was on.
Just tell me.
Thanks, John. I was on a meeting with Health Canada yesterday, so I was just a participant in a webinar. Yep. And I think that the UK, from what I understand, they have now said that no one with any kind of food or drug allergy should be getting this vaccine.
For the time being, correct, yeah.
For the time being. Yeah. So the message I saw from Health Canada yesterday was that if you have an allergy to something called propylene glycol, you should not get this vaccine. So that is yesterday's information. Everything changes so rapidly these days. It's important to clarify, but that was their recommendation. So I looked up the non-medicinal ingredients in the Pfizer vaccine. So we know it has the RNA, okay, but there are always buffers and different salts and things that are put into the vaccine to make it stable. This is a preservative-free vaccine, so they don't have a preservative in it, but it does contain this propylene glycol, polyethylene glycol, okay?
Polyethylene glycol.
That's right. So polyethylene glycol is derived from petroleum. It's a polyether, it's a large molecule, and they're using this together with something called ALC0315. It's got a huge chemical name that I could read, but I don't want to bore you. And it sounds like these lipids are what are forming the nanoparticle to protect and surround the mRNA. Okay, yeah. So it is important to the vaccine, but the suspicion is that this polyethylene glycol may be what could have caused these reactions. Now, there are other ingredients in the vaccine. So there's a few salts, so potassium chloride, sodium chloride. There's a sugar in there as well, and water for injection. And all these things are there to stabilize the vaccine. So we do see polyethylene glycol very commonly in society. It's in many foods, manufactured foods, and many cosmetics. I actually just went around my house today quickly, and I found products that have polyethylene glycol.
Oh, wow, yeah.
So this is an after sun gel. This is hand soap, children's toothpaste, deodorant, and a cleanser. So, I mean, this stuff we are all exposed to this on a daily basis. Now, we are not getting this injected on a daily basis. But the other thing with this polyethylene glycol is it is used as a laxative in some pharmaceuticals. But when it's used like that, it's not absorbed into the body. It just kind of flushes through. It's called an osmotic laxative. Yeah. So that was interesting. But I did find that there are some injectable products that do contain this ingredient. So this is not like the first time that this has been used, and I can provide the references for your viewers, in the video description. So it's not the first time, but at this point, it is interesting that Health Canada has flagged the polyethylene glycol and put that as a precaution rather than just a broad, any allergies to any food or drugs do not take.
Interesting. Right.
So we will see how that develops.
So I'm not concerned about that for me, but for people that are sensitive to allergies, this would be a good thing to know about. Potentially use something else.
And allergists can test for this, so they can do a skin test. And
right. And just put a little bit under the skin with a micro injection
and see if there's a reaction.
If it goes red, then you've got a reaction to it.
But if you don't have allergies, you've not had allergies in the past. For myself, I do not see this as a concern at all.
No, I feel the same. I'm still not quite sure why it's in the vaccine. Why is the polyethylene glycol there, do you think?
So they had to put a lipid bilayer.
Oh, it's the lipid, right? I've got it's part of that. Got it.
And that's how it gets into the cell. That's how it crosses the cell membrane. So it is quite vital to the vaccine.
Yeah, got it. So we can't inject the RNA on its own. The RNA is actually in a lipid little micro bubble. So if you imagine my pen is the RNA. Mm-hmm. Then that's got to be in this lipid bubble, and we inject it as the lipid bubble.
Because if you don't have that, it cannot cross the cell membrane and get into the cytoplasm.
That's right. because the RNA itself, I think, is water soluble, so it won't get through the fatty cell membranes. We have to have a fatty layer around it.
Yes.
Because it's a fat soluble layer to get it into the cells. And it's only when the RNA is in the cells it can give the genetic information to the protein making equipment in the cell to put the amino acids together in the right order to make the right spike protein that then goes to the surface of the cell, which is then recognized by the immune system. So that makes perfect sense to me now. So that's interesting. I do know that the Pfizer and the Moderna vaccine have a different lipid core around about their RNA. And that is largely what explains the lower temperatures that's required by the Pfizer vaccine, which is -70 for transport, as opposed to the Moderna vaccine, which is only -20, normal freezer temperatures for vaccine. And the difference there is not in the RNA, although the RNA does code for different components of the spike protein, as we understand this now. But they do have this different fatty layer around about the RNA that accounts for the difference. So, but this is the first time it's done. The Pfizer vaccine could well develop to use the same similar components, but be stable at a higher temperature. That's quite feasible. That's right. This is the first one. So I agree with you. A few allergic reactions in people that know they have this. Let's just hold off on these people for now and work out exactly what's going on. But overall, it doesn't concern me. We do see allergic reactions to medicines. And we ask about this and warn about this. And I think the other reassuring thing is these complications that can happen in the allergic reactions. In hospital situations, we are very good at recognizing all of these and very good at treating them all.
That's right. Yeah,
we can do this very well. If it's bad, then we need to give someone adrenaline or epinephrine, the EpiPens, the adrenaline pens, in the more severe reactions. But even if it's mild or if it's severe, we're actually very good at treating these in the healthcare situation where all the vaccines are given at the moment. So
yes.
I agree with you. It's not a concern, and I don't really think it's going to influence vaccine rollout very much. Now, we have these drugs called proton pump inhibitors that lower the amount of hydrochloric acid in the stomach. And I know you've been doing quite a bit of work on this, Lindsay. What's your latest research into acid-reducing medicines in the stomach?
So this is interesting. We know that the proton pump inhibitors, some examples of them are like rabeprazole, esomeprazole, omeprazole, pantoprazole. Those are some examples.
Sounds like they all end in azole.
Yes, they do, but they're not antifungals like itraconazole or something like that. But they do have the azole group. So
it's all the PPI groups,
Yeah, so these are very widespread, and I did speak about this on my previous video with you. Now, I wanted to point out that in no way, shape, or form am I suggesting you stop your proton pump inhibitor. So this is an acid reducer, okay? And part of the reason for that is, I mean, of course, we're not giving that kind of advice on this channel, but also if you do that abruptly, you could get what we call rebound acid production. So your stomach could actually start to produce more acid even than before. So there is a way to come off of these, but you need to do that with the advice or from the advice of a healthcare professional like a pharmacist or a physician. So that is something that I wanted to point out. Now, in the study that I showed on my channel, it was showing how the SARS-CoV-1 virus could be more prevalent in people who have been using a proton pump inhibitor.
You mean the SARS-CoV-2 or SARS-CoV-1, Lindsay?
Well, in the literature, there is evidence of SARS-CoV-1, and then in the study that was done, there was evidence that it could, the acidity of the stomach could have an impact on inactivation of SARS-CoV-2, meaning that the acidity of the stomach is an important factor in reducing viral load and even bacterial infection, okay?
Yeah, so this is work done from way back in 2003 when the SARS coronavirus 1 pandemic was there. That elicited quite a lot of scientific studies. And one of those studies showed that the natural hydrochloric acid in the stomach has an antiviral component to it, an antiviral effect.
Yes, and also antibacterial. And so the question that you had posed to me that I did not give you a very good answer for was, if this is a respiratory virus, why would that be affected? Why would people who are taking a proton pump inhibitor be more affected, by a respiratory virus that we know is in the respiratory tract, and that's how it gets into the body? And so we know that the SARS-CoV-2 virus does latch on to the ACE receptor.
The ACE2 receptor,
the ACE2 receptor. And these receptors are actually quite prevalent in the intestinal tract. And we have seen live virus in feces, and it's been tested. And we do see that people who are on proton pump inhibitors for a longer time can be more prone to intestinal infection in general. Right. So I would say that the idea behind this is not ludicrous. I think that it is reasonable. And the study that I showed also showed that, there is more of a chance of having these types of infections if you are on the medication twice daily as opposed to once daily, and even less of a chance if you are actually on a histamine antagonist. So that would be like a famotidine or ranitidine or something like that, because those are not as effective at raising the pH of the stomach. So I just kind of wanted to point that out. Yeah. And there are some things that you can do to help to reduce the production of stomach acid, or to help you if you're having any kind of indigestion, heartburn, reflux, that kind of thing. I brought them out here so I don't forget any of them.
Yeah, please do.
So things like chocolate, caffeine, even acidic citric juices, and large fatty meals can actually relax the sphincter between the stomach and the esophagus and cause that acid to be able to come up more easily. So if you can avoid those foods, that's very helpful.
Just say again, Lindsay, chocolate, caffeine, fatty meals.
Fatty meals and acidic citric juices. So I would say that's probably orange juice, any kind of
citrus juices,
juice like that. It can just kind of irritate and relax that sphincter. So also, no lying down after meals, no snacks within 3 hours of bedtime. Yeah. Some people actually will elevate the bed somewhat so they're not getting as much reflux. Of course, avoiding tight clothing, and also smoking can be a factor in this. So those are just some non-pharmacologic or non-drug options. But always consult with your pharmacist or physician before you're making any changes. What I would like people to do is start to think about what medications they're taking and why. And if they don't know why, start to ask why.
Absolutely. So as on this channel, we always recommend talking to your, never taking medical advice from us. We don't give medical advice. Always ask your own doctor, your own pharmacist.
Yes.
On a personal note, I'm really, really bad at late night snacks.
I've seen that's become more prevalent actually during the pandemic.
Terrible. I know I'm going to bed about 11 o'clock, say, but 9:30, I think, just eat something.
Yes, my husband has the same problem.
Yeah, it's a generic weakness, I think, but
challenge. Yeah.
And it's usually something inappropriate as well, like a bag of crisps or.
No, you're never going for an apple at 11 o'clock at night, right?
Yeah, but it's I've done some work in India. And the Indian cultures, they tend to eat very late in the evening.
Yes.
And this is a very common problem. So this is always part of the health education advice in India. Have your tea at 6 o'clock, not at 11 o'clock immediately before you go to bed. And but of course, it's true for everyone, and it includes my late night snacking as well.
It does. Sorry, John.
Yeah. Now, it's always a trade-off between things you like doing in the short term and long-term benefit, isn't it?
Mm-hmm.
Yeah.
Definitely is.
Yeah. Lindsay, so looking forward to more on the mouthwash.
Yes.
Thanks for your clarification on the vaccine. Hopefully next time you'll be reporting on a success. I'm sure next time you will be reporting on an initial successful rollout of the Pfizer-BioNTech vaccine in Canada.
Yes.
Hopefully by then we'll get authorization of the Moderna vaccine as well. I am expecting that.
Yes.
And I remain optimistic about authorization for the Oxford AstraZeneca vaccine as well.
Definitely.
Certainly by the end of the year, I'm optimistic about that. So we're going to have lots to talk about if anyone chooses to come back in. Thanks again, Lindsay.
Thank you very much,
fascinating.
John. All the best.
Yeah, just love proper science. There's no substitute for it.
I agree.
Yeah. Okay. Thanks,
Okay.
Lindsay. Thanks for
Thank you.
coming back. All right, bye.
Bye.